I want to say a few things about this report and the background. So Minority Rights International, in cooperation with the local community partners in Ethiopia, are implementing a project titled From Disparity to Dignity, Realizing Indigenous and Minority Rights in Development. The overall goal of the project is to address the discriminatory barriers in law, policy, and practice that prevent Indigenous people and ethnic, religious, and linguistic minorities from enjoying their economic, social, and cultural rights on equal footing, and support their effort to advocate and claim their economic, social rights through different human rights and development oversight mechanisms. The project has been supporting ethnic minorities and Indigenous peoples to prompt duty bearers to be more responsive and accountable to their obligations to tackle economic, social, cultural rights discrimination in all its multiple forms. And one of the aspects of this project is production of what we call national briefings. So far, we have produced national briefings for Kenya, for Uganda, and now we are launching the national briefing for Ethiopia. The project is being implemented in other countries with our partner, Economic and Social Rights Center, who are in New York, but we are implementing a project in Egypt and also 2 other countries, one in Latin America and another one in Asia. So basically, we have the briefings ready, which we will share through the chat box. We will share the PDF of this document. But first, we will listen to the panelists. After their presentations, we will share the full report. So it is just 12 pages of a report, which we have here as the national briefing for Ethiopia. We hope you will enjoy, and also we will hear from Araso, who has also with our partner organization, that is the Slum Rural Health Initiative of Ethiopia. They have conducted research in Addis Ababa, and also they have also looked at one of the pastoralist communities, which is an indigenous community in Ethiopia. We will hear more details from them. So to start with, Mr. Keremiu Wekeshe Wana is a senior researcher and a public health consultant who has ample working experience with several international and national organizations that are working in East African region. He has also served in different capacities with different organizations, ranging from program director to CEO levels. In addition, Mr. Keremiu has been involved in several global publications and contributed to international academic research journals. Currently, he has founded a consulting firm. He has founded a consulting firm called Afrinet Consulting, and he is the managing director at the firm. So he is the author of the report which we are looking at today. So I want to take this special opportunity to welcome Mr. Keremiu to make his presentation. Then we will ask questions later. So Mr. Keremiu, you have 30 minutes. Please make your presentation.
All right. Thank you, Joe, for that brief introduction. And hello, everyone. Good morning. This is morning from our side, East African time. So I'll say hello to every one of you from everywhere joining this meeting. So I'm going to display the slides, brief slides that I prepared for this presentation. Can you see? I appreciate if you tell me whether you see the slides. Can you see the slides? Hello?
Yes, we can see.
Yes.
Proceed.
All right, thank you. This is basically the national brief for Ethiopia on access to education and health among minorities and indigenous people in Ethiopia. So for complete, full understanding of the report, I hope that will be accessible shortly. Is that right, Joe? That will be accessible, right? So that will be released shortly after this launching event. So you'll get that. But for the sake of time, I'm going to focus on the main content of the brief. All right, let me do the introduction. Where this brief conducted in brief about brief introduction about the country as a whole. So as you may know by now, Ethiopia is a home for 80 nations and nationalities. We are multi-national, multilingual country, and we have more than 80 nations and nationalities. Out of these 80 nations, around 54 of them found in the southern nation and nationalities and people region. Currently, the nation has divided into 11 federal states. The addition of one state has came very recently. I think it's on 2022, on 2020, on March or February, if I'm not mistaken. So until then, we've been 10 state, federal state government. So the new state is called Sidama Regional States, one of the part of the Southern Nation nationality states in previous federal structure, but now it's independent state now. So according to 2007 census, that's the latest census we had. The majority of, I'm talking about the number, the majority of the population of Ethiopia are Oromos, accounting for 34.5%, followed by Amara, which is 26.9%, and the others are relatively minorities, like Somali is 6.2, Tigray is around that, around 6 million, so 6%, I mean. So the rest of the population are minority. As you can see, I already mentioned few nations, few tribes here. The rest, like more than 70 something nations are almost, you can say they are minorities in terms of number. And also the country is also a multi-religious country. We have the ancient country in accepting Christianity and also Islam, and with several sects of traditional religion. This is the current structure of the country. As you can see, if you see my cursor, can you see this Sidama state? This is a new state, which was part and parcel of the Southern Nation nationalities and people states. Now it's independent state. The other is a similar structure, federal structure of the previous map. So on access of education, when we talk about access of education, we are talking about availability of resources, availability of infrastructure, availability of human resources and other resources. So when we talk about financial resources, about 50 to 60% of the funding comes from the federal government. So from this alone, you can say that the educational program is more centralized, more controlled by the federal government, and the Ministry of Education is taking the leadership role, especially on those universities. We have over 40 public universities that are directly managed or controlled by the Ministry of Education. The other is the medium of instruction on primary and secondary education. Primary education is a mother tongue. Secondary education all the way to tertiary education, university education is English. So when we see about the budgeting that I depicted earlier, in 2020-2021 fiscal year, the national budget, around 56.8 million of the national budget, which is, by the way, the second highest next to roads, has allocated for education sector development. This is huge commitment from the government, I can say, policy commitment. The other policy commitment we've seen over last decade is education sector development program, which has 5 different categories that stretch ASDP 1 all the way to ASDP 5. So the latest has been launched to 2015 all the way to 2020. So what is this education sector development program is all about? Its purpose is aimed to the attainment and equitable access in line with increasing attendance, introducing okay, can you see me? Can you see me now?
We can see you. We can see you.
Yeah. So this program aimed the attainment and equitable access in line with SDGs, the Sustainable Development Program, which has to do with increasing attendance, which is a direct relation to access, introducing food ration package for schoolgirl and from pastoral communities. I'm like focusing on something related to what we are talking about. But this is not only limited to, these are not the strategies or programs or peculiar to health sector development program, but health sector development program includes this one as well in terms of accessing and making sure that the education is accessible to minorities and indigenous communities. The other, attract teachers to remote and ethnic minority areas through incentives and other measures that has been also clearly written on the education sector development program. The other is for those areas which are very remote and hard to reach areas, the program aimed to provide solar power tablet and also upgrading to alternative basic education centers to increase to that to 40% from where they were, from the baseline, which is less than 20%. So this is a huge boost. It's a double boost for the government to plan this way. But we'll see in the later slides how this is successful and how that has been translated to benefiting minorities and indigenous communities in Ethiopia. Okay. The other policy commitment is Pastoral Area Education Strategy. This also launched by the government on 2008, and they have established National Council for Pastoral Education, and which is aimed at to support the development and management of recruiting facilities. Developing facilities, recruiting human resource, and also nutrition and sanitation as well. Because livelihood has, the impact of livelihood has direct role in access to education, as you will know. You all know. So making sure that this underlying factor has to be addressed to secure access to education. So this program also a little bit comprehensive than the other truncated interventions, which includes nutrition and sanitation as well. So this is also another policy commitment from the government. The other is the National Plan of Action for Action of Persons with Disabilities, people with disabilities, persons with disabilities. So which is published in 2012, stretching all the way to 2021. So basically this program is addressing the myths and misconceptions and underlying prejudice and stigmas towards people with disability. So this is also a huge contribution from the government. The other is Special Need Inclusion Education Strategy. This also launched together with the National Plan in 2012, following the ratification of United Nations Convention on Rights of Persons with Disability. This is the United Nations Convention. So this is, Ethiopia also adopted this convention. So based on this, in line with this UN convention, the government established this one, Special Need Inclusive Education Strategy. So this is also one of the commitments that the government has shown for minority indigenous communities, including people with disability. All right, so what has been achieved here so far in terms of making sure the access for education? The first one, Ethiopian educational outcome have improved significantly This will be translated in 5 points. One, primary school enrollment has been doubled from 40.2% in 2000. I'm talking about Gregorian calendar, to 84.6%. This is a huge boost from the government. Actually, this is not the credit entirely goes to the government, but the other astonishing fact is that Ethiopian health budget, both health and education budgeting, a huge chunk comes from the international donors. So international stakeholders also take huge credit on this, boosting and increasing or doubling the primary school enrollment. UNICEF has been in place for decades, if not for centuries in the country, almost. I mean, half a decade and more in the country. So they have been contributing a lot on this. The other net secondary school enrollment has also raised from 12.5% to 30.8%, which is also double as we compare to for the last 15 years when we compare 2000 data to 2015 data. The other gender disparity in educational access have also narrowed. This has to do with many factors. This require a political decision, awareness, and addressing those myths and misconceptions deep-rooted in the community toward this women, toward this female and girls. So the disparity has been the gender disparity has been narrowed from, as you can see, from in 2000 it was like between male and female it was 46% to 34%. That is male to female ratio. But in 2015, as you can see, from 87.7 to 81.4, which is very close. So the gap, the disparity, the difference between the gender gaps has been narrowed between these 15 years. The other is the number of qualified teachers in general education system has also almost doubled. I'm referring to 2013-14 to 2017-18 data. That's the latest data I found on this particular parameter indicator. So as you can see, the number has been almost doubled, as you can see. So this is also a huge boost. The other at tertiary level, growth rate of enrollment of students has increased from 1.2% to 9.6%. Still, the figure has improved a lot, but still 9.6 is very few as we compare to even in developing nations in East Africa, even in South Asian countries. So we have improved, but the number is still small. So there are a lot of work to do. There are regional inequalities. Still, this is what I'm talking about. The children enrollment, primary school enrollment has been doubled, but as you can see, still there are 14.4% of students, primary students, are out of school. You see that this figure is huge. So if you see in number, you see 1.something million girls and are near to 1 million boys are out of school. So we have to do research and get tackle those underlying factors to bring all students, every boys and girls, to bring every boys and girls to school. The other, poverty, geographical distance, and chores, living condition, poverty, especially on those minority communities, it could be factors. Like, I'm not concluding, but this is very apparent reasons why still school boys and school girls are not at school. So the poverty, geographical distance, very remote areas, minorities and indigenous communities are living in a very remote and harder to reach areas. So this requires special attention apart from what the government has been doing here so far. The other is due to the existing traditional gender norms. I have already addressed this one. That's also, it has improved for last 2 decades, but still a lot to be done to further narrow down the gender disparity gaps. So large number of displaced and refugee children in Ethiopia also face additional barriers to access to education. It is unfortunate that the recent war has been broke out and a number of people have been displaced due to that war. That's not only peculiar to Tigray region, that's also affecting Amhara, also Afar, generally Ethiopia as a region. And the recent drought in the southwest in Borana, Oromia region, also devastating. So these are increasing the refugees. That means the primary victim of this war and refugee displacement are children and women. That's also part of the minority indigenous community. So these are kind of factors, combination of factors that are affecting leaving children out of school. As for tertiary education, lack of trained teachers, staff, limited equipment, poor infrastructure have also contributed to university setting. That's also apparent. We have improved. There are several universities. Previously, there were like 12 or 13 public universities. On over the last 2 decades, we have increased to 30 something, now 40 something. So public universities have grown, private universities have been grown, but still there are limitations on it, some universities. If you see new universities, you cannot find enough infrastructure, you cannot find educated and more experienced teachers and professors as you can find in Addis or Jimma or Gondar universities. So these are a kind of limitations that the report has come with on tertiary education. Among minority communities, just I'm highlighting this one because I've already mentioned some of them. Pastoral and minority communities are collectively making up to 12 to 15 million in the country. This huge number, very huge number. So for some countries, this is the entire size of the population we're talking about. So 15 million populations of minority need attention. So this is begging for priority from the government, from international stakeholders, and organizations like minority right groups. So the lack of even basic infrastructure among minority communities leading to migration and climate change. The one I already mentioned, the situation in Borana, is a climate change. It's a drought that lead to lost maybe hundreds or thousands or tens of thousands of cattle and destroyed lives of many families, which is also minorities. So this drought also has impacted, and migration also. That most of the minority communities are pastoral communities, so they are migrating from one place to the other for grazing land, for better lives. So as they migrate, they need infrastructure. They need those basic needs. So at the moment, with war in the north, the economy has been crippled, and the government doesn't seem capable of addressing or meeting those needs for minorities. But recently, there are good initiatives that have been done from the government. The other, for instance, one is alternative basic education, mobile schools, distance learning. That's the policy measures that have been taken by the government. From UNICEF side, for instance, flexible school timing have been designed. Like you cannot have regular schools and regular education system for minority and indigenous communities, especially those living in the pastoral areas. So this is a flexible schooling time. Culture sensitive and gender sensitive measures also has also taken. That due to this, the previous achievement that I presented has been scored. Okay, let's see some figures from EDHS, Ethiopian Demographic and Health Survey, which was the latest on 2016, the complete EDHS that I'm talking about. So if you see those regions believed to be home for many minorities, like Somali, Afar, SNNP, sorry, Somali, SNNP, Southern Nation Nationality people, and Oromia, of course. If you see those figures are very small. For instance, if you see literacy level, look, the Afar is here. The huge is no education. The literacy level on Afar is very poor, with 68.7%, and the highest is Somali, 75.3%. That's where minorities are reside, and also where is I'm looking for Oromia. The figure also is not small. Half of the population, women population, I'm talking about here, women literacy level is disaggregated by gender. So women literacy level is 50%. It's less than 50%, almost 49% in Oromia. Sometimes the figure misleads because Oromia is the largest region. The number of population also number one. If you see 51% means the number of population is very high. Afar is a small population, but the figure seems very exaggerated. But the number is higher in Oromia than in Afar or in Somalia or anywhere else in the country for that matter. So it's half of the women population is illiterate. That means huge concern. That primary school attendance also, when you see primary school attendance, those regions are very poor record. Like if you see SNNP, Southern Nation Nationality, 73.3%. So these numbers are not small. These numbers are very huge. It needs attention. So secondary school education, the highest number is only Addis with 13.7%. The rest are very poor. You can see it's less than 2%, most of them. So that means access to education is something we should do a lot in the coming years, together with the government and other stakeholders. How we see access to education among people with disability. I'm referring UNICEF data. Almost 7.8 million people in the country had disabilities. This is also half of the minority population, you can see. If you see the previous slide, are about 15 million of Ethiopian population are minorities, right? So almost half of this population, by figure I'm talking about, have been living with disabilities. So when we see from the national figure, it's about 9.3%. So it needs attention. It's not a small number. So around 2.2 million people had very severe disabilities. When we say severe disabilities, they need medical attention. They need support from the family member or from the facility-based support. They need financial support. Everything, every support we need. So they need like medical support, financial support, maybe housing and those related support, basic needs, access to basic needs as well. So 2.2 million people. So there's a lot of people to to address. Again, most of these disabled people are children and aged population, more than 60. If you see 13% of them are aged population and 1% of are less than, under 18. This is actually what I found from UNICEF, because most of the reports, this kind of data are not rigorously studied and also clearly reported. So the figure might be higher. The other survey conducted in 2015-16, 43% of children with disability had never attended school, compared to the national average, 22%. So if you compare the national figure with disability, the children with disability are unable to attend school for obvious reasons, for the reasons that I mentioned earlier, and also for obvious reasons that they don't, we don't have special, though we have policies, those policy commitments that I shared earlier, the government has policies, but when we go down to the community, you cannot find, you cannot see that translated on the ground. So 43% of children, disabled children, are not at school. This is due to limitation of limited recognition, the resource given to cater for their specific needs in mainstream schools, and poor living condition that they have. Okay, I'm speeding up a little bit. Okay, access to health. 31% of health expenditure is out of pocket. Can anyone answer this question? Why this is a problem? Why this is a problem? 31% of health expenditure is out of pocket. What did this tell us? Anyone from the participant side? You can show me your hand. Okay, Geoffrey, go ahead. You're muted.
Sorry, I was actually checking the participants.
Okay.
Sorry, I wasn't meaning to raise the hand.
Okay. Anyone from the participants? Why this figure, or in general, out-of-pocket expenditure is not favorable? Aranso, would you like to start on this question?
Pardon me your question, Gary.
Out-of-pocket expenditure. Why is not encouraged? Why we don't? Why we want people to get into health insurance instead of out-of-pocket expenditure?
Yeah, thank you. Actually, in most countries, it is encouraged to be have health insurance, but in our country, health insurance is a recent phenomenon, and it is only a few individuals who have access to health insurance, as you already said. Most of them have out of pocket, and that is not encouraged, because if it is out of pocket, during difficulties, they can't afford some medical procedures. They can sometimes also it resulted in unnecessary loss of the asset they have. Some of them are forced to sell their land, their house, and the other things. But in case if there's a insurance that can cover it, but in our country, it is a recent phenomena, and the government, I think, started to work on this. And even the current things we have is only covering certain health-related costs, then not to do with that of health expenditure that need some referral to abroad or other, or within the country that need high costs. That is the reason, I think.
All right, thank you. Yes, in addition to what you said, some of the healthcare expenditure are very expensive. For instance, chronic illness treatments are very expensive. Some surgical interventions are very expensive. Some medications are very expensive. So for those reasons, people are encouraged to have insurance, which is inaccessible at the moment for everyone. But still, with that inaccessibility, people are encouraged to join these community-based health insurance schemes. So out-of-pocket expenditure forces people, or the client or the patient, to incur more costs, unexpected costs, unplanned costs. So That's the reasons why we encourage health insurance. But as you can see, about 31% of health expenditure is out of pocket. That means we need to work a lot to move people from out of pocket expenditure to health insurance scheme. Besides the financial challenge, accessing adequate infrastructure, training personnel in remote areas can be very difficult. This also I have mentioned while I was presenting about access to education. The same is true for access to health. The policy says every health center should be built within a radius of 10 kilometers, but that doesn't seem applicable for minority communities. So the policy is good, but the implementation is still lagging behind. Even physician to people ratio also very high. 1 physician to 13,000 people, which is the 2018 figure, which is very recent, of course, 4 years back. There might be a little bit improvement, but still the figure is very high. No question, it is already approved by the international community, by WHO and the United Nations, that Ethiopia has achieved some of the maternal indicators of MDG, Millennium Development Goals, and reduced morbidity due to HIV, malaria, and tuberculosis. But the emerging chronic illness, the global pandemic, COVID, and all that, other health conditions have been threatening the country and taking millions of lives. So still the attention is diverted, but the progress has been made on those particular public health problems, but still there are different public health problems, not to mention the COVID pandemic and the emerging chronic illness in the country. So the significant progress at the national level has not been distributed equitably with minorities and marginalized communities. That's what I said already. This is mainly due to harder to reach very remote areas, the residential areas, also the factor. So this, sorry?
You have 1 minute remaining, so maybe I add you 2 more minutes.
All right. Sorry.
Okay,
sorry. Let me go this through quickly, and one more, I'll finish. So this is also very significant graph that talks about multidimensional child deprivation. There are a number of criteria that put into this around 14 or 30 categories that agreed between Ministry of Women, Youth, and Girls, and also Ministry of Education. There are criteria. Based on that criteria, anyways, you can find online that multidimensional child deprivation is very high in rural communities. As I said earlier, most of minority communities reside in rural areas, so they are victims. Children of minority communities are victims of this multidimensional criteria, like access to food, access to health, access to basic facilities. So those children are victims, so needs attention on that. You can find this detail on the report. Another important figure is maternal indicators. As you know, maternal indicators. Let me talk about only one figure: child mortality, under 5 mortality. Under 5 mortality is very high, as you can see here. Very high. This figure seems small, but when we translate that into numbers, are very high, especially when we compare that to developed nation. Is under 5 mortality is very high, antenatal care is very low, institutional delivery is very high, as you can see. Vaccine coverage is also very poor, and women's circumcision is still very high. You see this, the figure is it's the figure, a recent EDHS, Ethiopian Health and Demographic and Health Survey, 2016. So this is very critical variables that we need to see. All right. So let me conclude, Joe, for one more minute. So despite Ethiopia's significant progress in education and health in recent years, significant gaps remains, those gaps that I already mentioned. This is especially evident at the regional level. When I say regional level, apart from Addis, so most of the regions are affected by this, poor outcome of health and education indicator. So addressing this complex mix of social inclusion, stigma, poverty, geographical factors, institutional failure that contribute to the difficulties that the country is facing, obviously. So we need to address those issues: social inclusion, we have to address misconception and stigma, we have to address poverty, and also we have to address geographical factors through infrastructure building. Joe, thank you so much. These are recommendations you can see from the screen. Thank you.
Well, welcome, Jeremy, and thank you for the wonderful presentation. Thank you very, very much for this detailed and in-depth analysis of the situation in Ethiopia. And for those who are joining late, the main aim of this national briefing for Ethiopia was to identify or to find out whether there is disparity in access to education and healthcare in Ethiopia based on gender, ethnicity, race, or geographical location. So it is clear, maybe in summary, from your presentation, Jeremy, that there is multiple discrimination in Ethiopia. There is what we call intersectionality. Healthcare. Further, we have seen from your presentation that we might be having progressive laws, policies, and regulations in Ethiopia, but at the end of the day, their implementation might be in question. For example, you talked about the establishment of National Council for Pastoralist Education, but when Araso would be making his presentation, we will see that even if we have this progressive policy,
Joe, I think
some of the pastoralists in Ethiopia. We have seen also the issue of gender inequality has come out very clearly from your presentation. We have seen that more girls are out of school. They are not attending school compared to boys by a large margin. Also, we have seen that there is also a disparity in access to education when it comes to refugee children. So when you are a refugee and you are in Ethiopia, you are more likely not to have access to education or healthcare. And finally, we have seen geographical disparity. That if you are a child who is under 5 years old, is in Addis Ababa, is growing in Addis Ababa, that child is more likely to access education and healthcare better than someone who is in a far region. What I've picked out from your presentation is that some of the regions are lying behind, especially I saw Afar when it comes to most of the parameters which you are looking at. So basically, I know the next presentation from Araso, Baru, who conducted through his organization, is a co-founder of Slum and Rural Health Initiative. They conducted research in Addis Ababa to look at the language barriers, and also for the E2 and the Gereyu communities, that is pastoralist community, we will share with us. But before we go there, now this is time for participants to ask questions. And I've started seeing some questions here. Okay, this is just a comment. So feel free to ask questions. Use the tab for Q&A. Q&A is down there at the bottom of your screen. And also you can raise up your hand. So I will be checking who is raising up their hands, then I will ask you to speak. So please feel free. We are starting with Omer Shalek. This is our colleague from Yemen. He was with us in Canberra. Please ask your question. Omer. You can also type your question. We will answer your question as soon as we can. Please, Omer. Maybe we need to. Okay, please. Sorry, maybe we can unmute Omer to ask his question. So Jeremy, you can see the question from Fatima.
Can you hear me now, guys?
Yes, we can. Please proceed.
Hi, and good morning, everyone. Thank you for organizing this interesting webinar. My name is Omar from Yemen, currently in Lebanon. But I'm Signalo Girmao for this interesting presentation.
Thank you.
Actually, yeah, I'm following the situation in Ethiopia within the current conflict in Tigray region, and I would like to ask how the access to health and education is affected with the current conflict. Thank you.
Okay, I think let me take this question and I'll come back to Fatima. You all right?
Okay, good. Ish.
All right. Thank you, Omar, for that very critical question. Yeah, actually, the war has affected a lot of things in the country. As I mentioned on my presentation, the entire economy has been affected, meaning lives have been lost. There is very terrible situation we are in at the moment due to this unnecessary war. But when we talk about education, for instance, if I give you one example, the 12th grade student should have write their exam this May. I'm talking about 2021, but they haven't due to the war. And I don't think they are going to take anytime soon. That's one of the direct impacts on high school education. Even for a university education, they haven't even get their grades, their transcripts from universities like Mekelle, Adwa, Shire, Aksum. These are the universities found in the Tigray region. So some of them, some of them already affected by the war. Who knows? Maybe they have died due to unprecedented war. Those who survived relocated to other universities, which is also delays their progress in the university, in their university education. So primary and secondary education, that would be very, I cannot tell, even no real situation, and we don't know the real situation in the Tigray at the moment for primary education. Did I answer your question, Omar? I think while Omar is responding, let me quickly respond to Fatima's question. Yes, Fatima, that's right. The figures are, sorry. Actually, that's the circumcision, the rate of circumcision that I presented. The figures are high because there is improvement. There is improvement. I mean, sorry, let me. Joe, can you hear me? There is some noise coming.
Yes, we are hearing you.
Yes.
Hello?
Yes, we can hear you. Proceed, please.
Yes, I think Fatima is referring to the presentation slides that I shared about maternal indicators. Circumcision rates are very high. Yes, there is improvement. Female circumcision also high, especially on those Somali and Afar regions. Some of the neighboring towns or zones of Oromia region as well to the Somali. This is, so I have done research on this, by the way, on women circumcision. Though most of the religious leaders, most of the community leaders seems against it on public, but behind the scene, they do that's clitoridectomy, the first type of FGM, female genital mutilation. There is no infibulation like before, but the third type, the serious type one, but they do still clitoridectomy when I do FGD and key informant interview with the religious leaders. They do that as they told me that some kind of ritual, still some sort of religious issues, but publicly they denounce that, and also it is illegal to do female circumcision. But though also this data is, don't forget that this data is from 2016 EDHS. So the recent data definitely will improve the figure as well. Fatma, did I answer my question, your question?
Okay, I think they can, if you did not answer, probably they can make a follow-up question on the Q&A. So you can proceed to the Tekere's question on Q&A.
Let me see. Okay.
He's saying, he's thanking you for the nice presentation. What are the recommendations on reducing those inequalities in terms of accessing education and healthcare among minorities?
Oh, yes. Yes, that's a nice question as well. Yes, the recommendation, actually, I was run out of time. That's why I didn't put my recommendation. I have like 5 recommendations I put in on the slides. The first one is ensuring educational service by delivering cultural appropriate fashions. Culture is very important, that the way of life. So we need to understand the minorities' culture and the way they live their life, the way they understand the education, the way they understand the modern healthcare system. That's the one thing. The other is infrastructure that, like I said earlier, we have to get to where the people live. I think that's one of the health for all goals. So we don't have to wait for client or patient to come to health institution, but we have to go to the place where people live and make sure we grant access to them. The other, we need huge investment, of course, when we talk about infrastructure, when we talk about training human resource, when we talk about making those equipment available, or sending teachers to remote areas, incentive mechanisms. This all requires, enormous resource. So resource mobilization also required, and also collaborating with stakeholders and policy reform also required. So these are kind of recommendations that I give on the slides.
Okay. Thank you, Jeremy. I think we will share the presentations with everyone who is here, so they can get to read the details and also the report, the full report. So sure. Let me see. Another question. Please ask your question as we proceed. If there is no additional questions, then we can move to the next presentation, where we will be looking at the research at the state level, at the specific communities now. Any question before we move? Let me see. If there is none, we can. Let me see. I think we have answered all questions, so we are free to move on to the next presentation. So we will share those with you after this. So the next presenter is Araso Baru Orani. Mr. Araso is a lecturer at Abuminchi University, where he has been teaching as well as researching since 2014, and is also the co-founder of Slum and Rural Health Initiative, Ethiopia. This is the organization we are partnering with, and there are others which are coming in other series of presentations like this one. So Araso has worked before with MRG as an intern, and He is also a researcher for various organizations, including Federal Ministry of Health, Emergency Directorate, Addis Ababa, Ethiopia, where he published over 10 original research articles in peer-reviewed reputable journals. Araso holds a master's degree in health science in reproductive health from University of Ibadan in Nigeria, and also another master's in science in emergency medicine and critical care from Addis Ababa University in Ethiopia. Araso believes that all mankind should be equal, should get equal access to healthcare and education, regardless of their race, religion, gender, and cultural background. So Araso is going to make a presentation on 2 areas. The first one is a research which they conducted in Addis Ababa, looking at language barriers. And the next one will be a research they conducted among the E2 Kareyu community. It's a pastoralist community. It will give us more details. So Mr. Araso, feel most welcome and make your presentation.
Can you see? Can you see it? Can you see it?
We can see it. Please proceed.
All right. Thank you for the nice introduction. I'm Araso, and I will present 2 topics. And the first topic will be the state of access to health and education among linguistic minorities in Addis Ababa, Ethiopia. And I will give focus on Apanoromo speaking population. So we did research on regarding all minorities when they seek healthcare in Addis Ababa. From the background, language is very important, particularly in the context of healthcare, particularly to receive quality healthcare. Also, for access to healthcare, language is very important. And as healthcare provider, ability to explain, to listen, and the empathy patient feeling, because is very important to provide the healthcare service to the patient. They take history. From history, they observe a lot of things. They counsel the patient. So the role of language is very important in providing healthcare service. Similarly, the language barrier between teachers and the students is also influential. That is why most of the country, and including the international organization, is recommending primary school in mother tongue. And I will give focus more on this. The Ethiopian government issued a new education policy in 1994. According to that new education policy, every citizen, all nations and nationalities in a country have the right to receive formal schooling, particularly primary school in their mother tongue. This is also part of promoting their culture, as well as is part of learning by their own language. This is international right also. And the Ethiopian government also ratified several international laws and regulation, including that of Mascara's guideline on violation of economic and social rights, as well as Organization of Africa Union 1981 Organization of Africa Union Convention. According to that right, every citizen or each nation and nationality living in the country has the right to access to healthcare for its citizen without any discriminatory background, without any discrimination. However, access to healthcare and the language in Addis Ababa is somehow different from what we have in a policy. For instance, generally speaking, Addis Ababa is composed of multicultural and multinational. Currently, due to different reasons, there are indigenous communities in Addis Ababa, as well as different peoples are coming from each parts of the country to reside in Addis Ababa for different purposes, maybe for work, for trade, for other reasons. Because Addis Ababa is the capital of city of Ethiopia, that is the reason why each of them come to the city. There is also currently internal migration is high. Ethiopia is previously agrarian society, and most of them live in the rural area, but this thing is currently being shifted and the people are traveling from rural to urban, and Addis Ababa is ideal destination for most of the people. So there is a multicultural, multilingual, and also when we come to the Addis Ababa's City Government Charter Proclamation, Article 5, Sub-Article 2 of Ethiopian Federal Constitution, and the modified Addis Ababa Charter declares that Amharic is working language of the city of Addis Ababa, and federal policies, federal offices also. Most of the federal offices are within Addis Ababa as well. In accordance with this legal framework, all hospitals in Addis Ababa and tertiary hospitals, that is where referral made from different parts of the country, work by Amharic. That is because it's official language and the official language of the city as well. In accordance with this, despite the patients from diverse social background, there are patients coming from diverse language are meant to receive healthcare from those hospitals, but the city is not providing the language service, and this is what we did. Why we did a research how the patients are facing challenges, difficulties due to the language barrier. There is no language access service in the city for healthcare, so that access and the quality of healthcare service for indigenous community and linguistic minority in the city are being compromised. Similarly, with regard to access to education, Addis Ababa is not only the capital of Ethiopia, it is also the regional capital of Oromia regional state, and there were indigenous communities, that is Oromo people, who is within Addis Ababa, as well as surrounding towns and rural areas of Addis Ababa. However, as I said before, the language service, particularly for education also, up to 2017, it was only primary school were given by Amharic, but in 2017, there was a recent introduction of Afan Oromo schools for primary education, and currently there are 4 schools that is providing primary education by Afan Oromo. Therefore, due to those barriers I mentioned, maybe language barrier in accessing education, as well as language barrier in accessing healthcare service, we aimed to explore a study in accessing health and education among Afan Oromo speakers in Addis Ababa. As a methodology, we did a qualitative research using in-depth interview as well as key informant interviews. Our key informants were particularly healthcare providers who had difficulties in language, as well as we had from some leaders who are currently working in healthcare facilities, particularly hospitals in Addis Ababa. We did also in-depth interview and we explored lived experience of the patients, the challenges they face in accessing healthcare. And the same we did for the school as well. Our main key finding, let me start with that of access to healthcare. Language barrier in Addis Ababa is existed. It is very common in when the patient that has language barriers seek healthcare services. One of our key informant feedback that she has been challenged in taking patient history. This language barrier is not only for the patient, also when the physician is unable to speak the language of the patient, they face a lot of difficulties. We explored a lot of information from that. Because of the language barrier, I hope some of you maybe have been in Ethiopia before, talking to someone who can't understand your language may be difficult. Imagine this is access to healthcare. Those are people in need. They need, this is about survival. They went to healthcare facility, and when they face challenge, this is another burden. And some of them, they face anxiety, distress. Some of them may feel ashamed. We will see about that. From the key informant also, because of language barrier, one of the key informants said, there are patients who do not know where to go and how to ask for help. Sometimes some of them move in the hospital facilities, move from one place to another. They don't know what to speak, how to speak, who should contact, because there is no language access service. There is no medically trained translator in healthcare system of Ethiopia in general and in particular in Addis Ababa. One of our in-depth interviews said is that can human and the tree communicate? This is from his own experience. This is what he said, he told it to us. It is like that. I cannot understand them. They cannot understand me. That is language barrier. So this is the way he's explained what he's facing due to the language barrier. There is also what we have found is there is a use of ad hoc interpreter. Generally speaking, ad hoc interpreter is not encouraged in most parts of the world because those ad hoc interpreters are, they don't have formally training to translate one language to another. But in this context, in Addis Ababa, a patient who have language barriers coming from various parts of the country, as I said before, there are minorities. They come from southern nation, they come from within Oromia, they come from Gambela, each part of the country, because the referral center we have in Ethiopia is concentrated in Addis Ababa. So what they do is the healthcare professional who wanted to help the patient seek ad hoc interpreter. Those ad hoc interpreters primarily sourced from the patients themselves, other patients who can speak the same language and at the same time who can speak Amharic. They can be also from the patient attendant by self. It can be also from healthcare professionals. The problem with ad hoc interpreter is that it breaches the privacy of the patient things, particularly when family member translates the issue of the patient to healthcare professional. It is breaching the privacy of the patient. This is a breach. In addition, it is also healthcare. It is also exposing the information of the healthcare professional to others who shouldn't listen what should be. So such thing is happening. In addition, those those ad hoc interpreters have no formal training. As a result, they do not translate some words, some terminologies that is medical in nature. So the healthcare provider face some challenges with that. But it is obvious in Addis Ababa, they use ad hoc interpreter because there is the system is not hiring someone individual that is medically trained and that can make a translation service. I will make some recommendation about that at the end. The other thing we found is poor adherence to prescribed drugs. The patients have reported a poor adherence. We also heard from healthcare providers through our key informant. They told us poor adherence. For example, sometimes some drugs are prescribed to the patient to take 30 minutes before eating any food. But the patient takes those drugs 30 minutes after eating food because of those inconveniences related to language barriers. Sometimes the patient is the drug is prescribed to the patient to take twice a day. The patient may take 3 or 4 times a day or at a time due to the language barrier. And such thing is a serious issue, and it is making health inequalities that could have been prevented. The other thing is missing follow-up to appointment. Some of the patients, they may have come early to their follow-up, they might come later to their follow-up, or sometimes they miss at all. They do not come for follow-up due to the language barrier. It's also, there are some complications that could be prevented. The physician order or may inform some possible complications that may happen due to the procedures, but the patient may not understand due to the language barrier. And this is what one of our key informants said. I remember the patient who underwent a surgery for congenital anomaly. We gave the patient an appointment and with the help of translator, and they went home. We believed that they understood everything we told to them, including possible complications. But they come after 3 months with very critical condition, that's life-threatening condition, and the surgery was performed for the second time. The second surgery performed was unnecessary for that particular patient, but it was happened due to the language barrier. Such thing is a frequent experience in each hospital we have in Addis Ababa. The other thing is extra cost to the patient. Some of the patients come up with their attendant, unnecessarily, the additional attendant who can speak the official language that is spoken within the city. Some of the patients also stay for days without getting any single procedures or without contact with physician. Also, there is a condition where physician order unnecessarily the examination or laboratories because the patient can't explain his or her condition. So they order additional laboratories to find what was the cause of the disease to help the diagnosis. So those are extra costs to the patient. Extra costs. This is a frequent condition and it is affecting also the patient outcome. There is also poor patient-provider relationship. Generally, there should be a strong relationship with healthcare provider and the patient. But due to the language barrier, it is affecting the relationship between healthcare provider and the patient, and this is affecting also the outcome of the disease condition. Some of the physicians say some of the patients are thinking they are not receiving any treatment because of the language barrier. They perceive that they are not receiving anything from the physician, anything from the hospital because of the language barrier, even though the healthcare providers are trying to help those in need. There is also a violation of patient privacy, as I already said before, because due to the language barrier, some of information of the patient is being shared with attendants, other ad hoc interpreters, and other peoples. So there is a breach of patient right privacy, and this is ethical dilemma actually. The physician the healthcare provider do this one because of the fact that they want to help the patient. On the other hand, also, they are breaching the right of the patient. But if we have medically trained interpreter, the patient can also speak some things, even sensitive information, particularly related with sexuality issues, sexually transmitted infections, because they don't want to talk such things with other, for example, HIV positive patient who has sexually transmitted infections. They don't want to talk with family members. But if we have a doctor, if you have medically trained interpreter, or if they can able to speak the language of the physician, they can reveal such information, they can disclose. But this is what the patient is facing due to the language barrier in Addis Ababa. The other one is dissatisfaction and the anger. The patients are dissatisfied with the service. Such thing is also happening. They are also facing anger. For example, there are many patients who reported perceived discrimination. They perceive because they don't speak the language of the official language, so they perceive they are being discriminated. On the other hand, also they perceive that they are not receiving equal service with others who can speak. Sometimes they are also ashamed of themselves for not able to talk the language of the official language of the healthcare institution. The other key finding we have also in access to education. I have done with that of access to healthcare because I only presented pertinent finding. We have also with that of access to education, there is a shortage of infrastructure. As I said, up to 2017, there was no school that provide primary school in Afan Oromo, and Oromo is indigenous to Addis Ababa. So up to 2017, for example, when you hear about Oromo, as Garamo presented before, it is the most populous, one of the most populous tribe in Ethiopia. But in terms of language, it is minority even within its land. Here, up to 2017, it was denied. Nowhere in the world that deny the language service to office to its majority, even in the world. But this is what these people are facing in Addis Ababa. So in 2017, Addis Ababa is about like over 500 square kilometer hold over 500 square kilometer, but within Addis Ababa, there is only 4 schools that is providing. So students are traveling over 30 kilometers even to reach their destination, to reach their school. And also even those schools built are, there is no enough infrastructure. There is shortage of classroom, there is lab facilities, mismatch between the number of students and the toilet facilities. This is what happened to school compared to those schools that deliver schooling in status quo, like Amharic, that is already providing with in Amharic. The school lacks playing ground, recreational areas, and Addis Ababa has about 11 subcities currently. And in those 11 subcities, it is only 4 subcities that has schools that provide primary school in Afan Oromo. As I said, The city holds over 500 kilometers square land. So it needs more school. And the book shortage is also a common phenomenon, particularly those books are not currently printed by the municipality of Addis Ababa. They are taken from Oromia Regional Education Bureau. So they are not printed by self, and the students are, there is a shortage, and there is mismatch between the number of students and there is the book they are getting, even the basic books, the teaching books. And there is also no libraries. Such things are not common from our observation and from what we see. Family of the students are also paying extra costs. As I said, the students are traveling from long area, distant areas to get education by their mother tongue. As I said, there is only 4 schools that provide a primary school in Addis Ababa, so they travel from one subcity to the other, so they are subjected to pay additional costs. Due to distance, the students high pays for transportation service, and the family of the students are exposed to different things. The other thing is physical and psychological attacks. Physical and psychological attacks to the student, to the teacher, even to the security guards of those schools. As is a recent phenomenon, there are some people who do not want to have a school in Addis Ababa that teaches by the Afan Oromo language. So the physical attack, verbal abuse were frequent experiences to students, security guards, and some of the teachers. That's what they told it to us. As a recommendations, there is a need to introduce healthcare service in more language. In more language. I'm not talking about only that Afan Oromo. There are minorities, as Garamo said before. There are over 80 minorities in Addis Ababa. So they need medically trained interpreter. Maybe we can have a dedicated service, for example, for some of the language, we can have those referral centers when they can receive a medically trained interpreter. So linguistic minorities these medical interpreters are urgently needed for linguistic minorities within Addis Ababa, because access to healthcare is human right, and the system by itself is making a discrimination. Even though Ethiopia has signed a lot of ratifications or ratify a lot of human rights, international human rights, regional human rights. So the system by itself is making a disparities in accessing healthcare, and even this is from the disparity to dignity, because people are ashamed of their identity because they can't get access to healthcare by their language. Building more schools that can operate in mother tongues of the indigenous community would avert inequalities in accessing primary education. This is my first presentation, and I will proceed with the second, and the latter I will take some questions and answers from the participants. The second presentation is the state of access to healthcare and education among Itu and the Karayu pastoralists in Ethiopia. These are indigenous communities. Actually, there are about over 15 million people who is currently practicing pastoralism in Ethiopia, according to the recent data from UNICEF. And most of those pastoralists are found in Afar, Oromia, Somali, and the southern nations. Pastoralists are disadvantaged group in accessing healthcare and education compared to other segments of the population, compared to those who are settled population. Pastoralists in Ethiopia are characterized by low immunization rates, where we compare with settled population, low institutional delivery rates. Most of them are delivering at home in 21st centuries, when the government, when different stakeholders are working and building and training manpower, but the pastoralists are still, most of them are delivering at home by traditional birth attendants, low enrollment rate in education, high school dropouts, particularly during the dry season. They move from one place to another to find food for their cattle. Very low completion rates, school completion rate. And the last time, even when we do our positive dialogue forum, there are schools in our areas in where we did a research, there are schools that is even sitting 1 to 2 students for primary school completion. Imagine, only 1 to 2 students. During enrollment, there is high enrollment maybe, but during the national examination, there are some schools that is presenting 2 to 3 students for a national examination and for primary school also. Ensuring access to primary healthcare and primary education responsibility of every government and widely accepted in the world. However, pastoral in Ethiopia are prevented from this type of service due to a range of barriers, such as cultural barrier, economic barrier, lack of awareness, system factors, lifestyle in the community, and there is also geographical barrier. This is what we got from previous researches, and we have also our own. From perspective of health for all and education for all, this is what Ethiopian government is currently practicing. The Ethiopian education and the healthcare system have considerable limitation in reaching pastoral communities because it is favoring already settled population, and there is very limited, maybe as a policy, as Berremo said before, they have as a policy to design a mobile school to reach, to provide food service to pastoral communities. But practically, what we are currently seeing is different from this, and it is favoring a static institution. And the curriculum by itself is not flexible. It is not the calendar that is working for settled population is still working for the pastoral communities. So they are facing a lot of challenges. We did the same methodology. We had FGD, we had key informant interviews, we had also in-depth interviews. The common identified barriers are toward accessing healthcare and toward accessing education, seasonal droughts, which is leading to, this is very common among pastoral communities. And even today, nowadays, we have active droughts in Somali region. We have active drought in Oromia and Afar, and even within Itu and the Karayu pastoralists. So recurrent drought and the climate change is very common to Itu and the Karayu pastoralists in particular, and in general to all pastoral communities in Ethiopia. So seasonal drought forces Itu Karayu pastoralists to internally migrate, which is leading to losing or loss to follow up to essential care service such as immunization, antenatal care service, as well as to school dropouts. Particularly during the dry season, and this is what they are facing now. The school calendar is inherently in favoring permanently settled population. It is not flexible. It is not working for pastoral communities because dry season in Ethiopia, like currently in January, February, like that, there is schooling, but it is dry season for pastoral communities. So at this time, it should be closed actually for pastoralists, and for settled population, they can learn, but it is the design is fixed and it is not flexible. Therefore, pastoralist children are usually forced to stop schooling during dry season. Cultural susceptibility of healthcare as well as cultural susceptibility of schooling. Similar to most pastoralists in Africa, distrusting modern healthcare programs such as immunization is common to Itu and the Karayu pastoralists. With the same is true for education, like the firstborn male child is not allowed to school, fearing the men do not marry on time. This is what's common to pastoral Itu and the Karayu pastoralists. They are not allowed to study because of fearing of the men may be delayed to marry or delayed marriage, or maybe fearing of continuity of the generation. They give more priority for continuity of the generation than to be enrolled in school. Similarly, also with regard to the gender, females are not encouraged to study modern education. This is their belief. They are born to give birth to child. This is what the way they believe. And even during our positive dialogue forum last time, this is what we identified. It is still continuing, and they need more action to prevent such actions. There is also geographical barrier. With regard to healthcare service, they are traveling as high as 30 to 35 kilometers to reach healthcare facility. With regard to education also, they are traveling about 15 kilometers. Imagine those school children between 6 to 10 years, they are forced to travel about 15 kilometers to reach school on foot. And even this thing is worse when during the dry season, and they can travel more beyond this to reach schools. They are also not getting school feeding because Currently, the Ethiopian government started to provide some feeding at the school, but mostly such things is being given to the towns and the cities within Ethiopia, and the pastoral communities are not being benefited from such action. So they are forced to travel cross hills and rivers to arrive at school at their early ages. Shortage of infrastructure. All right. I'm about to finalize.
You have 2 minutes.
All right, I'm about to finalize. The primary school in state area lack classrooms. No school in the district have enough classrooms. In many primary schools like Liba, Haroba, we can mention those and you can find later. Most of the students are forced to sit on stone as they have there is no chair in those schools. Healthcare facilities in rural area do not have access to services such as water, electricity, and housing for staffs. And actually such thing is common in rural area, but it is worst among pastoral communities. As a recommendation, Ethiopian health and education system need innovation to make service more readily accessible to pastoralists. Each and the Karayu pastoral need culturally competent healthcare and education that harmonize local culture. Pastoralists need a separate academic calendar from settled population. This is what we have identified. Thank you very much, and you can ask any question.
Okay, thank you very much, Araso Baru, for the wonderful presentations. As you can see, so many things are coming out of these presentations. We have seen the conflict between policy and practice. What we have seen overall at the federal level, the picture is so good at some point, but when you go to practice at the community level, from what we have seen in Addis Ababa, and that is for the Afan Oromo, and also for the Itu and the Kareyu pastoral communities, some of those beautiful or flowery things happening at the federal level are not actually reaching the farthest to reach populations, that is the indigenous people. We have seen the situation of insecurity in access to education, for example. It's so unfortunate that some people are attacked for teaching in their mother tongue in Addis Ababa, that's Afan Oromo, which is already in the policy, that is the education policy, which allows children to get educated in their mother tongue. Then we have also been shocked by the fact that in some communities, for example, the Itu and the Kereyu, only 2 to 3 students sit for national examinations sometimes. We have also heard from you that, or we can make conclusions that mobile schools are not working if Itu and the Kereyu pastoral communities, their pupils cannot continue schooling because of drought. Because I think that policy for mobile schools, the one for pastoral education, should have provided mobile schools to follow these pastoralists wherever they are going. And then there is lack of infrastructure for schools, inadequate personnel for both schools and hospitals or health facilities. So now I open up this for questions. Then we will answer them from, Araso will answer them from here. So you can raise your hand so that I can be able to see who is asking questions. But as we proceed to those questions, I will read some comments. Agnes Kapachuni is saying that, Araso, thank you so much for that interesting angle to access to health and education. The impact of language identity and autonomy in accessing health and education of most marginalized ethnic minorities or linguistic minorities, if you like. Thank you, Agnes. I think Araso has taken note of that. Fatma is saying, we need to do lots of sensitization to the Itu Kereyu concerning education. It is very wrong to deny the boy child education just because he's the firstborn, because they believe educated men marry late. Okay, thank you very much, Fatma. So now we open up this for questions. Please, Jeremy, you can turn on your camera as we answer questions. So anyone who is raising up their hand, I'm checking, sorry. You can raise your hands feel free so that our panelists can answer the questions as they come. Meanwhile, panelists, you can feel free to go through the Q&A. If you see additional comments or questions, we can address them before we close. We have 10 minutes to 1 here in East Africa. So I think.
Actually, yeah, in the meantime, I want to do some correction. Fatma reminded me, that's a very critical question. I think the table, I've sent you the revised one, and I hope that will be made corrected.
Is there a table which you are specific table? Maybe
yes, on access to vaccination on maternal figures. That's a aggregated table we're talking about. So slight modification on the figures. I think that's a mistake made while copying and pasting. So the figures should be right when we're releasing the report. Otherwise, we're good to go. Yeah, thank you.
I think we can address them before we get the hard copies. Yeah. Okay.
Yes, thank you.
On Q&A, I'm just reading. But before, as we wait for others to ask questions to Araso, Jeremy, you can answer a question from Agnes. I don't know if you had answered. Your findings are very important, especially as we should think of taking this lack of disaggregated data campaign to the regional level. I don't think that's a comment. It's a good comment.
Yeah, I think I have addressed on the previous questions that Agnes forwarded to me. Yes, well, that's one of the limitations we are facing at the moment. Lack of the disaggregated data. That's mainly because of the absence of the research on a particular parameters or a particular criteria is needed to be studied. So, for instance, if you are looking for rate of child days or rate of maternal days among some particular minority communities, you cannot find that data online or from the Ministry of Health either. What you find is aggregated data as a region, or maybe as if you get the best data, if you get is as a zonal level. You cannot find even at Wereda or a small structure of the community. That requires conducting primary data by your own. Joe, are you there? I think you. Hello?
Yes.
Can you hear me?
Yes, we can hear you.
Did I answer your question, Agnes? I don't know. Let me hear on Q&A, or you can tell me verbally.
Okay, I don't think if there is any additional questions for us.
Yeah. Can you hear me?
Yes, Agnes, I can hear you.
Oh yeah, Jeremy, that's a wonderful presentation, and so is Araso Baru. That was very, very captivating. My interest was on the issue of lack of available disaggregated data. And I'm looking at the experience of Ethiopia being so similar to the situations we are unveiling both in Kenya and Uganda from this study, is that to me, it takes me to understanding of government recognition of the issue of ethnic minorities, all linguistic minorities, in terms of specifically targeting disaggregated data by ethnicity, not as an issue of a divisive issue, but an issue of being able not to leave them behind. Because if until we have that kind of data disaggregation as a pinpointing particularly on data collection of ethnic minority as a category, just like the way we say women, disability and others, then we cannot have it. And it's an issue that is challenging on the issue of reporting on SDGs. Country reports for the SDGs, they will continue to miss out on the status of the most marginalized ethnic minorities or linguistic minorities in that kind of order. So I think we need to do something about it. At the government level here in Uganda, I'm trying and I'm setting up meetings with the SDG offices to see, can we influence the data collection? Because if the data is not collected, it won't be recognized, it won't be there, and therefore action won't be taken because data informs plans.
Yeah.
That's
a very critical point, actually. Yes, that's similar situation we are in Ethiopia as well. But it seems like government is not interested on finding those disaggregated data. It's solely left for organizations like UNICEF. For instance, UNICEF publish data every time that fits into their needs, which may not be even helpful for us. Sometimes helpful, sometimes may not be helpful, because the data that we are looking for and the data that they are publishing is quite different sometimes. So we try to get different documents, that published documents, to extrapolate the data that we are looking for. So yeah, I share with you the concern, and that's also critical. And maybe we think about that if the SDG team has budget for that and they have priority on that, we can partner with them to get those data, reliable data for our reporting and using as a baseline. Otherwise, we have to engage in collecting those primary data by ourselves. Thank you. Joe, you are muted.
Sorry, I think so far so good. We have answered questions, which were presented under the Q&A. So now, because of time, we will close here at this point. I want to take this opportunity to thank all panelists for making time to prepare these good or wonderful presentations, and for generating the final report, which we will make the small adjustment, which you mentioned, Jeremy, and then share with the rest of the participants. And also I take this opportunity to thank all the participants who took their time to be part of this conversation. Thank you, the technical organizer. We have someone in the background making sure that everything is working here. It's my colleague, Mihaira. So thank you very much for making sure that this thing has worked very well. And also those who have asked questions, thank you very much. And keep asking this question. Once you get that email with the presentations and also with the final report, continue asking questions. And more importantly, if you are coming from Ethiopia, we will continue with this advocacy at the ground level. The next report, which we will be looking at, is coming from the Consortium of Ethiopia Human Rights Organizations. That is ZERO. They are also looking at another community in Ethiopia. We will continue with this. We are doing what we call tailoring it to specific places so that that kind of advocacy can be done in that region. So now the next level will be meeting policymakers, discussing with them, raising awareness on the issues which have been discussed here today. And our major aim is to seek change. We reduce the disparity in access to education and healthcare for indigenous peoples, for ethnic minorities, linguistic minorities, what we have seen in Addis Ababa, and many more. Thank you very much. See you in our next episode. Thank you very much.
Thank you, everyone. Thank you, Joe. Take care.